You see, last time we were approaching a case of hip disease, and we have said that hip disease is suspected when there's pain, swelling, deformity, loss of function around the hip. Now, this loss of function can be climbing up or down stairs, walking, single limb or double limb stance, or sitting on a chair, cross-legged, or squatting. So when this is the presentation, we suspect hip disease. We ask the basic question, when were you completely all right, and then what happened? And we record the symptoms in chronological order. So you have recorded these symptoms in chronological order, and about each of them you answer onset, course, duration, treatment taken, response, aggravating factors, relieving factors, and associated factors. About pain, you answer site, character, intensity, radiation. And when you state this intelligently in a coherent manner, it is called as present history. Then you want to say, by this story, you try to build up a provisional diagnosis which says site of lesion, nature of lesion, cause, effect, and association. So this provisional diagnosis makes you answer some intelligent questions for positive or negative answers, and that is an addendum information to the present history. Then you ask past history, then in this you primarily ask the comorbidities which can affect your diagnosis or treatment, like diabetes, hypertension, heart attack, all those things. So after this, you ask the socio-economic history, and the socio-economic history is the effect that the disease has done to the life of the patient. You ask about activities of daily living. What is the problem in activities of daily living? What is the problem with vocation? What is the economic effect of disease? What is the resilience of the patient as to how much of cost he can bear to correct it? All right. And what is the effect on the recreation and social activities of the patient in terms of family and friends? So this is very important because this gives you the clue as to what should be the type of treatment the patient should receive. So then after this history, you subject the patient to a general examination, and that is the eye, the skull for rickets, eye for jaundice and anemia, oral cavity, mouth opening for endotracheal intubation, neck movements, then chest, abdomen, spine, sacroiliac joints, pelvis, opposite limb, same side limb, and other joints. Okay, so this forms your general examination, but of course you don't forget the pulse, respiration, blood pressure, and temperature. After this general examination, there is something special, which is related to hip examination, and that is any neurological deficit whether the heart and the respiration is involved, whether the spine is involved, whether there is a cold abscess in the abdomen, and what about the pelvis? And the spine includes the sacroiliac joints. So after that, you start examining the local examination of a hip, because if you omit all this and go straight to the hip, it is called as the red tag effect. You know, when there is a bullfight, they show the red flag, and the bull hits the red flag and misses the human being. So don't miss on this before you come to the local examination of hip. The most important things is gait. It takes a separate lecture for gait. Then single limb or double limb stance, standing on each of the limbs. Okay. Then you go to sitting. And if all these things are normal, painless and stable, then probably the hip is not involved. You can leave out the rest of the examination. And finally it is when the patient is lying. Now when the patient is lying, the headings are inspection, palpation, measurement, movement, deformity. Inspection, palpation, measurement, movement, deformity, special tests. So let us begin with inspection, okay? So this is the sternum, this is the spine, this is the abdomen, this is the umbilicus, this is the thigh, this is the knee, and here is the foot. So we begin with spine, level of the anterior spines, swelling, scar, sinus around swelling, scar, sinus around hip, then attitude of hip, knee, ankle, foot of both sides, right and left, then wasting, direction of patella, shortening, straight leg raising. Now this is straight leg raising and dorsiflexion of ankle. In palpation, confirm the findings of inspection. Inspection findings. And there are 5 T's. Temperature, tenderness, transmitted movements, telescopy, trochanter, thickening. Trochanter is thickening. Elevation, tenderness. Okay. After the palpation, we come to measurement. For the measurement, there is apparent length. And for the apparent length, you should remember this basic diagram. That if apparent length changes because of tilt of pelvis. So these are the 2 anterior-superior spines. The spine must be scoliotic. This side hip must be adducted. This side hip must be abducted. And naturally, since this acetabulum is higher, this should be shorter than this. So the physical signs related with apparent shortening, which is because of pelvic tilt, is scoliosis, raised ASIS, abduction attitude, and lengthening. Concavity of scoliosis, this is lower ASIS, raised ASIS, adduction attitude of hip, and apparent shortening. Now, why should this pelvis tilt? So, apparent length is measured from xiphisternum to the tip of the medial malleolus, with both hips parallel to each other and parallel to the trunk. And the physical signs associated with apparent change in length are scoliosis, raised or lowered ASIS, adduction or abduction deformity, and apparent or true shortening. Now, why should this pelvis tilt? This pelvis can tilt because there is a scoliosis. In this circumstance, you will never be able to correct the tilt. Then it should tilt because there is adduction or abduction deformity. What is the adduction deformity? Adduction deformity is absence of abduction beyond a particular range in adduction. So this is, since this hip cannot move out, therefore the pelvis will tilt so that this limb becomes parallel to the trunk. Alright, so second reason is adduction or abduction deformity. One, scoliosis. Second, adduction abduction deformity. And the third is that when this limb is shorter, then to bring it to the ground, the pelvis can tilt again. So the 3 reasons are scoliosis, adduction abduction deformity, and shortened limb. These are the reasons of pelvic tilt. Now we'll talk about true shortening. True shortening is measured from ASIS to tip of medial malleolus with pelvis square and both limbs in identical position. Because if this is the iliac crest and here you have a trochanter and here is the neck, if you abduct it, the trochanter will become closer to the ASIS and there will be shortening. So whatever is the degree of abduction on one side must be the degree of abduction on the other side also. The true shortening is measured from ASIS to tip of malleolus with with pelvis square, both limbs in identical position. And if there is a shortening, then you measure up to the adductor tubercle. Or what you can do, you can flex. If the knee is lower, then the thigh is shortened. If the heel is higher, then the leg is shortened. So these are the two tests. Measure up to the adductor tubercle or flex to find out whether the shortening is above the trochanter or below the trochanter. Then for if this is the iliac crest, this is the trochanter, this is the ASIS, here is somewhere where the umbilicus is, and here will be the ischial tuberosity. So from ischial tuberosity to ASIS is a line which is called as the Layton's line, where you will find the tip of the trochanter. If you project this line, it should normally go above the umbilicus. This is called as the shoemaker's line. Then you can join the trochanter of both sides and ASIS of both sides. This forms the Shinge's parallelogram. Finally, there is a right angled triangle. Hypotenuse is the line joining the ASIS to the tip of trochanter, and this is called as Bryant's triangle. If the trochanter is raised, the base of the Bryant's triangle will be shortened. So thus you find out whether the shortening is supratrochanteric or infratrochanteric. Then we come to movement. So here we will tell you that why should the movement be restricted. Movement can be restricted because the muscle is in spasm. For example, if this adductor is in spasm. So first what will happen, that abduction will become less, first stage. Then abduction will become absent, and then there will be an adduction deformity. So what is the adduction deformity? It's the position of hip in adduction beyond which abduction is not possible. So this is adduction deformity. So you must understand that less abduction is the same thing as adduction deformity. Now, one reason why the movement is limited is contracture or spasm. Now, this contracture and spasm will limit movement in one direction only. For example, if the adductor is contracted, it will limit abduction, but will do nothing to abduction. No effect on adduction. So this type of lack of movement is called as extra articular ankylosis. And any reason of iliospasm can lead to adduction deformity. The basic difference between this and hip involvement, intra-articular ankylosis, is that usually you find that the rotation will be free if there is a iliospasm which is extra-articular. And you will be able to find the cause of the iliospasm, like filarial lymphadenitis, appendicitis, or whatever. If there is involvement of the hip, so the first thing is that there is erosion of the cartilage, and there is spasm. There is spasm to prevent movement, night cries, and a range of movement is painful. But the second step is that there is connection between the two cartilage surfaces. This may be fibrous. So here the movement is absent and the attempt to move is painful. The third thing is that this can become bony. As it becomes bony, there is no movement, no pain. So tuberculosis stage 2 can be erosive, can be fibrous ankylosis. But septic arthritis or ankylosing spondylitis can lead to bony ankylosis. Okay. So extra-articular ankylosis, intra-articular ankylosis. Difference is that in intra-articular ankylosis, all three axes will become involved and both adduction and abduction will go. And there are three stages of intra-articular ankylosis: erosive arthropathy, fibrous ankylosis and bony ankylosis. Okay. So this is the movement. Now with a deformity, how do you find out the range of movement? So you test it on flexion extension axis. That means whenever there is a flexion deformity, the spine will become lordotic so that the limb can become parallel to the trunk. So if you flex the opposite hip and the spine becomes straight, then you can see the flexion deformity. But first you flex the opposite limb, then you extend the normal limb, and where it stops, that is the flexion deformity. This is called as the Thomas's hip flexion test. Now from this position you can flex the affected hip to find out range of movement, range of flexion. So this is flexion extension axis. Then there can be an adduction abduction axis. And finally, whenever you are testing an adduction abduction axis, pelvis should be square. And the third can be external internal rotation axis. After testing movements and deformity, you go on to test Morris's bitrochanteric test. That means from pubic symphysis, distance of the tip of trochanter. If it is closer, that means there is a central dislocation of hip. Okay. This central dislocation you can also test by a per rectal examination, per rectal or per vaginal examination. Then there are two other tests, Ortolani and Barlow. Barlow means in a congenital dislocation of hip, you can Baharlow dislocate the hip, and Ortolani is reverse, underlow. So Ortolani and Barlow test. So after this completion of the hip examination, you come to diagnosis. And when you come to diagnosis, you classify your patient into flexion, adduction, external rotation, then flexion, adduction, internal rotation, then flexion, abduction, external rotation, and then none of these. Now flexion, adduction, external rotation is if there is history of injury, it is fracture neck femur or fracture trochanteric. If the injury is present, if there is injury is absent, it is adolescent coxa vara or slipped femoral epiphysis or perthes. Right. Now, if there is flexion, adduction, internal rotation, you say whether there is shortening present or shortening absent. Okay. If shortening is present, there is dislocation of hip, posterior dislocation of hip, which can be congenital, traumatic, pathological, or paralytic. If shortening is absent, it can be intra-articular ankylosis, which can be erosive, fibrous, or bony, or it can be extra-articular iliopsoasspasm. In this, rotation is free and painless. Okay, extra-articular means iliopsoasspasm because of any reason. Then in a flexion, abduction, external rotation, you say mono-articular, which is usually due to septic arthritis, or polyarticular, which is because of ankylosing spondylitis. SA or AS. Okay. Then none of these, if there is history of injury, it is central dislocation of hip, central dislocation. Okay. And if injury is absent, then it is osteoarthritis, oblique avascular necrosis. So this algorithm will help you diagnose a hip condition. And after that we come to one of these conditions which is common, which is fracture neck of femur. And about this fracture neck of femur, we give you a scenario. That means an elderly lady, probably postmenopausal osteoporosis, slips and falls in bathroom. जमीन पे कपड़े धोते हैं उसकी वजह से, है ना? There's pain, swelling, deformity, loss of function around hip. There's a flexion, adduction, external rotation, deformity with true shortening above trochanter. There's tenderness in Scarpa's triangle. So this makes a diagnosis of fracture neck of femur. Clinical diagnosis is fracture neck of femur. The differential diagnosis is trochanteric fracture, where there will be more deformity because it's extracapsular, where there will be trochanter tender thickened, and here the tenderness will be in the trochanteric region. In the fracture neck of femur, it will be in the Scarpa's triangle. So trochanter is thickened and tender, and there is more deformity. More deformity because the fracture is extracapsular. The trochanter, if old, will malunite, and the complications of neck femur are non-union. That means you will not be able to raise the limb in air. Avascular necrosis, osteoarthritis, osteoporosis. Now comes the question of how would you investigate to assess the general condition of patient. Hemoglobin, TLC, DLC, ESR, GBP, BTCT, blood urea, blood sugar, urine and stool. Then you will take an X-ray of the pelvis, AP view, and lateral view. Now AP view, you have to answer 4 questions. Is fracture present? Yes, if the sentence line is broken. Sentence line broken. The second question is site, which is subcapital, transcervical, basal. Then displacement, adduction, external rotation, inflection. Then you have the classification, anatomical classification, Powell's angle, Gordon's classification. Powell's angle is from a horizontal line that you draw the line of the fracture. If the fracture is more vertical, then the muscle force and the ground reaction force will cause a shearing strain. This will move up, this will move down. So the fracture, if it is horizontal, these two forces will create compression. Otherwise, they'll create a shearing stress. So this is Powell's angle. The Gordon's classification is incomplete. Both cortices not broken. Complete, undisplaced, partially displaced, completely displaced. The partially displaced and completely displaced you find out in the completely displaced, the head and acetabular trabeculae are aligned. And here they are not aligned because the head is rotated. The neck, which is partially displaced, rotates the head. Fracture, closed reduction, internal fixation. Children may you use pins. In adult, cannulated cancellous screw. Not reducible, open reduction, internal fixation, and then you can plus minus graft. Then old, young patient, you do osteotomy. Angulation is more preferred as compared to displacement. Because of displacement, there can be overloading of head, especially in heavy patients. Then old person, head, you do a HRA. Head and acetabulum, you do a THR. Not possible, you do a excisional arthroplasty. Plus minus pelvic support, osteotomy to stabilize the hip after excisional arthroplasty and prevent progressive shortness. So this is the treatment of fracture neck of femur. So this is the sequence that you will be asked questions. What is your diagnosis? Why do you say so? How would you investigate? How would you treat? What is the prognosis? And I would advise you to write down your checklist and then examine the patient so that your examination is comprehensive, valid and precise and you leave out nothing. Thank you.